Hello, everybody. Thank you for joining us. We're all up close and personal. And so I'm going to talk about some cross-cutting themes in injury prevention today, not research or practice, just some observations. The first I wanted to start with, for those of us in public health, back in 1999 in Boston, we were at APHA, and Sue Baker, who is one of the internationally renowned pioneers of the field, received a major award for her work. And our own public health people sitting around us said this, like, well, what's injury prevention got to do with public health? Well, you could feel the shiver went through the room, and we were all so offended. And then I began to think, well, you know, the problem is that we are cursed with knowledge, is that we have no perception of what it's like not to understand about injury. And yet most people perceive data very differently. And so we're trying to persuade people with data that makes no sense to them. And just to sort of test this concept, I was wanting to ask you what this number means to you. Anybody? Small number? Okay. What if I put some context around it? This? Do we now know what that number is?
Number of people killed.
No, actually, it's the number of lives saved. It was the miracle. It was the miracle on the Hudson. You see, we're not all negative people here. Some of us. So yeah, number of lives saved in the miracle on the Hudson. And we all know the story that happened. There was the NTSB investigation and the report in May. There have been books written and documentaries. There have even been love stories of survivors and marriages. And then recently, those of us who lived on the 95 corridor witnessed this 788-mile procession as they brought the plane down to where it was supposed to go in the first place, which was Charlotte, North Carolina. So we celebrated this, we celebrated life and life saved and preserved this miracle. But what if there had been no miracle? What if 155 people had died that day in the Hudson? Then what? Would we have changed our national response to that event because people died as opposed to the fact that people survived? What if it hadn't been 155? What if it had been 500 people? Would our response have been different to that? And that's a really important question for us to answer, because when we break down this 187,000 deaths every year, that is 500 people every day of every year in this country. And that means that 3 miracles on the Hudson do not happen every day of every year in this country. I also want to point out one pathetic little thing, which is that these data are from 2007. The most recent injury data we have is from 2007. That says a lot about what we don't invest in data infrastructure in this country in terms of understanding injury. So how do we get to this place, right? So how do we get here? And I think what we need to understand is that we see the symptom of this here, in that we have this disconnect between the real need that we see, the perceived need, and therefore the priorities that are based on perceived need, and therefore the resources, both practice and research, the policies and the feasibility of being successful in the field. Those we can only be successful if we have intersection here, and we have very little intersection, which is a result of the perceived need not matching the real need. I apologize for the quality of these slides. We do have a handout in the back from the SAVER fact sheet. But what I want to show you here is that there's this disproportional funding of injury relative to its burden. So if we look at years of potential life lost, which is here, injury leads years of potential life lost, because public health isn't about preventing death. It's about preventing premature death and preserving quality of life. And so injury is hands down the #1 problem of premature years of life lost. But if we look at cancer, for example, and heart disease, the federal funding for cancer research into the National Heart, Lung, and Blood Institute was $9 billion, right, into FY 2008, whereas the research dollars for injury out of CDC were $134 million, despite the fact, that's an order of magnitude different, despite the fact that we actually have a bigger problem to deal with. So what does that mean? Well, what it means is that despite the fact that we have a huge champion in the National Center for Injury Prevention and Control, they are having to make some very difficult decisions about where they put their money, right? They are our friends, trust us on this one. But we now are down to 11 injury control research centers, our centers of excellence funded by the CDC, down from 13 last year. We're down to 20 state injury programs. So 20 out of 50 states have any money to support a core infrastructure to deal with injury in this country. It's absolutely extraordinary. And that means that we are up against a major skills and infrastructure challenge. So when I think about talking about the public health process of injury problem solving, we have to be able to identify the problem. We have to be able to analyze it and understand the risk factors and the solutions. We have to be able to design programs that are evidence informed and not just convenience decision making. We then have to know how to deliver the programs that we develop with enough resource intensity and sustaining that we get the impacts that we want. The problem with that is that we then need this all plays out within these social and political contextual factors. So it's not even as if they happen in the same way in the same states. Everything is influenced by these contextual factors and ultimately supported or not supported by infrastructure. Now, when I think about injury prevention, I think about two levels of infrastructure: the internal infrastructure that we place into public health agencies, and then the external infrastructure that we then bring to bear from the academic partners, the other state partners, and private public partners. But essentially, our epidemiology skills, our design skills, our information sharing technology, our level of social political influence, our research work, the evidence base that we use to design this is all dependent on the funding and the resources. And the fact that we have this adequate or inadequate or restricted funding, the restriction is also a critical issue for us, and the unstableness of the funding is a huge issue for us in terms of dealing with anything. And so when we put no money into something and say it doesn't work, essentially what we're doing is we're setting ourselves up for failure, for public failure, because the evidence is quite clear that what we're doing in many cases can't work because it's too little and not appropriately targeted. Now, so there are consequences to this resource deficit, not least the fact that we're missing opportunities to reduce the daily toll of injury. We are at risk for not sustaining our successes. We've had a lot of success, but if we continue to slash our resources like this, we're not going to sustain them. And we're also at risk of not building the new evidence and the new capacity we need to actually address injury. As a teacher, this terrifies me, this future expertise deficit. If we continue not to fund injury prevention research, then the bright academics coming out of universities will not make their careers in injury prevention, because you cannot survive in academia if you cannot fund your work. And so we see people going into obesity and physical activity. People who are interested in injury are working in areas outside of injury because they can't survive with the level of research funding. Similarly, in public health practice, where are our practitioners? Where is the career advancement path for people to assume leadership roles in public health agencies as injury prevention specialists? So how do we address this imbalance? How do we move this to a position of overlap? Well, here I want to come back and just tell you very briefly a little bit about myself, which is that I am a little bit patchworky in the way I think about life. I started life as a clinician dealing with neurotrauma in children, and then I became a researcher and a practitioner. But when I think about injury prevention, I find again and again and again that I think about it most as an educator. And so therefore, when I am faced with this kind of situation where I'm, say, teaching, and I teach hundreds and hundreds of people. We've taught 700 people through the Summer Institute. I teach medical students and pre-meds and grads and community and everybody. As an educator, my question is, well, why don't they get it? What am I doing wrong that they don't get it? And what I find is it's an issue of the lens that they're looking through. And so typically when I talk to even public health people, medical students, they all say, well, it's about the behavior. People are making unwise choices, they have freedom, they have choices, and then so essentially they think about behavior, they think about individual responsibility, they think about freedoms and liberties, and then they also usually come down on something punitive if people don't want to do what it is. And of course, if I'm dealing with the pre-meds, they're all invincible anyway, so they don't really mind. So then I say to them, okay, so if it's so easy, why is it so difficult to change unsafe or unhealthy behavior? And I ask them to own it and say, you think about your life. We're all very smart people. We could write books on how to be healthy and responsible, productive people, but we don't, because life gets in the way, right? And so one of the things that's really important, I think, for us to have society understand is that behavior doesn't develop or change in a vacuum. And if we continue as a society to ignore these social and environmental influences on our behavior, then we're never going to be successful in changing any kind of behavior, whether that's an individual's behavior or a stakeholder or policymaker's decision making. We're never going to do that. And we know in this caucus that public health relies on changing multiple determinants of health. We know that we've got to go after the access and we've got to go after the policies. But very often we're having these conversations about access, and so much money is going into access, but we ignore what are the immediate wins, which are the physical and social environmental changes. which are my major concern, and I think in public health need to be all of our major concerns.